For this video, I will use my book, the second edition book, so that you can see what it looks like. For the previous lectures, I was using my draft lectures, and this will be available the moment this lecture is live. Okay. When we talk about therapy related to psychiatry, one of the basic things that a person must have is the interweaving techniques. This is common for all other sections also, but let's discuss this here, because there are some disorders in which you need to confront the patient or you need to ask them open-ended questions, etc. So first, most important point is empathy is key. You need to have empathy when you talk with a patient. You need to understand where they're coming from. And there are different types of questions. The most commonly used questions as a physician should be open-ended questions. This is when you allow the patient to speak in their own words. You don't put any words into their mouth. You let the patient speak their mind. You can facilitate them by nodding your head, by silence, by saying all of these. Next, we have closed-ended questions. This is once we have come to a relative diagnosis, we can go for these types of questions. We don't give them options in the answers. It's either this or that. We don't let them tell you something else. We are asking them, which one is it? Next, facilitation, that is, you allow the patient to continue. This is a skill that involves you either nodding your head, saying and then even silence. You as a physician should never lead the patient to get the answer that you want. Now, when we take the exam, there's 4 specific things that will be commonly tested. One is suicidal patients. What do? You confront them. You need to ask them, do you have feelings or do you have thoughts of hurting yourself? Then in drug users, you need to confront them. You need to ask them, you are using alcohol, are you not? Or you need to confront these patients. Next, we have patients who are trying to quit the drug, maybe alcohol, maybe cocaine, any drug of abuse, and yet they come back to the hospital due to relapsing. So in this case, you need to ask open-ended questions to determine the cause of relapse, and you need to do something called motivational interviewing. This is when you talk to the patient in such a way that it motivates them to try again, to try harder. Next, patients who are suffering from gender dysphoria or sexual dysphoria. You need to ask them open-ended questions. Let them open up to you. Let them feel comfortable. And one very important thing, you should never assume anything about a patient. When a patient comes in, that patient might have marks that they are drug users, but do not assume they are a drug user, because when it comes to the process of interviewing, if you confront them, they are more likely, even if they are not a drug user, they are more likely to not trust you, to not want to continue giving you an open discussion. So in sexual dysphoria patients or gender dysphoria patients, you need to ask them open-ended and gender-neutral questions on their identity and sexual identity. The next part is antipsychotics, and we have already discussed in the topic schizophrenia, but we will go in detail about each of these drugs, their side effects, and which drug to use where. Now, there are 2 groups. There's the older generation called the typical antipsychotics. These are the first generation. And then there's the second generation, atypical antipsychotics. And obviously, since the second generation ones are newer, they have lesser side effects and better modes of action. So the first generation antipsychotics they inhibit dopamine receptors and variable inhibition of other neurotransmitter receptors, such as histamine receptors. But the second generation inhibits both dopamine and serotonin. So this means you can treat both the positive and negative symptoms. Whereas in typical antipsychotics, mostly the positive symptoms are treated. Again, there is variable inhibition of other neurotransmitter receptors. Typical antipsychotics are of two types. There's the high potency and the low potency. And we need to know the drugs which belong to each category. Haloperidol is the most commonly used high potency drug. Then the low potency drugs include clopramazine, thioridazine, and they have two specific side effects which you need to know for USMLE Step 1. Clopramazine is associated with risk of corneal deposits, while thioridazine is associated with risk of retinal deposits. Next, we have the atypical antipsychotics, and in this table I have added the most important points that you will need when it comes to questions. Risperidone is associated with the highest risk of metabolic and endocrine side effects. We will talk about these side effects, but there's a lot of weight gain, and also the prolactin related symptoms that we discussed in schizophrenia occur here. Next, we have Olanzapine. This is also associated with high risk of metabolic and endocrine, but if a question asks you to pick between the two, go with Risperidone. Next, we have Quetiapine, and this has the lowest risk of movement side effects if you don't consider clozapine. Clozapine is one of the best drugs we have in the antipsychotic category, but then because of a side effect, a single side effect makes it very difficult for us to make it the main treatment for psychosis. Risperidone, it's associated with prolonging QT interval. And from these drugs, I want you to remember this one also, lurasidone. We will come to this drug. Now, we use these drugs to treat schizophrenia, any bipolar affective disorder, organic psychiatric disorders, Tourette syndrome, motor disorders, agitation. Agitation, this is treated in the hospital. Intramuscularly, you need to sedate the patient. You need to stop the agitation. We will come to that. Let's talk about the side effects of antipsychotics. Before we go into the anticholinergic effects, let's go into the anti-dopamine side effects. We already discussed this in the schizophrenia chapter, but let's go through this again. Acute dystonia is a movement disorder that occurs within hours to days of starting antipsychotic therapy. This time frame must be known. So the patient will present with spasms of various muscle groups, such as the neck, and something called oculogyric crisis, in which the eyes move up, but they cannot bring it down. There can also be laryngospasms, and this may require intubation. This is more common in young men. The causative agents for this are the old high potency drugs. Now, it's important to know, if they ask you a question and they give you haloperidol and clopramazine, the answer is obviously going to be haloperidol. If they give you haloperidol and a newer drug such as Olanzapine, again the answer is still haloperidol. Treatment for acute dystonia includes benztropine, diphenhydramine, trihexyphenidyl, and you can prevent this condition by administering along with the antipsychotic, because the moment a patient would get these symptoms, they will stop using the drugs. They will be worried and they will stop using the drugs. So you need to prevent this from happening by administering the following drugs, such as benztropine, this is the most commonly prescribed, with the antipsychotic. Next, we have Parkinsonism. This is the same 4 symptoms that we learn in Parkinson's disease. There's muscle rigidity, resting tremors, an expressionless face, and bradykinesia. The treatment is to decrease the dosage or discontinue the offending medication. And you can give them anticholinergic. See, the same drug comes again, benztropine. Next, we have akathisia. This is simply generalized restlessness. These patients will be pacing, they will have abnormal leg movements, they cannot sit still and stay. And again, the causative agents are the older drugs compared to the newer drugs. And high potency compared to low potency. Treatment for this is a benzodiazepine or a beta blocker. And if it is possible, switch the antipsychotic that you are using. Next, we have the most severe complication of these. The symptoms above will usually stop once you stop the medication. But tardive dyskinesia can be permanent in patients. This is due to chronic dopamine receptor blockade in the basal ganglia. So this causes supersensitivity of the postsynaptic dopamine receptors. And this, again, this time frame is very important. Rarely occurs before 3 to 6 months into therapy. This is most common in elderly females, and they present with tongue protrusions. They put their tongue out. They can't control this. Then there's facial tremors, shuffling gait. Think they have abnormal facial movements. That's the main way that they will describe a case. They will tell that the patient is protruding her tongue. And again, like I said, this persists after stopping medication. Parkinson's drugs may aggravate symptoms. Now, this fact is very important. Let's say a patient comes with the Parkinsonism symptoms, and you find out that the patient is on antipsychotic therapy. You should never give them drugs such as levodopa, because this will aggravate psychosis. You need to give these patients benztropine. And for tardive dyskinesia, there is no treatment. Prevention is key, and they have found out that clozapine may reverse tardive dyskinesia. They are doing research on that. And we use newer antipsychotic medications because they have reduced anti-dopamine side effects. Vitamin E may help. Next, antipsychotics have anticholinergic effects, and in the questions, you need to look for a patient who's delirious. They will have delirium, mad as a hatter. There will be dry mouth, constipation, confusion, and they would present acutely, especially in older people. There's going to be postural hypertension also. And this is very important. In older people, there's a risk of falls. So we need to be very careful when we prescribe antipsychotics to these patients. We will talk about that and how to prescribe. Next, there are antihistamine side effects such as sedation, weight gain, and endocrine side effects due to the inhibition of the infundibular pituitary dopamine pathway. There's going to be gynecomastia, galactorrhea, amenorrhea, sexual dysfunctions, all because of the increased levels of prolactin. When dopamine is low, that causes prolactin to increase. And risperidone is the drug which has this side effect most severely. Next, there is a very important side effect, that is cardiac arrhythmias. This is specially associated with haloperidol. But in general, you should remember that patients who are on antipsychotics have a higher risk of QT prolongation. Another name for this is torsades. Next, let's talk about the potency and the side effects. The high potency first generation all have high degree of extrapyramidal symptoms, but low cholinergic effects. Then when we take the low potency drugs, they have a lower incidence of extrapyramidal symptoms, but a high incidence of anticholinergic effects. And again, let's go through these points. These are very important. Older patients are not given first generation antipsychotics due to high risk of falling, orthostatic hypotension, and other anticholinergic side effects, unless benefits outweigh the risk and the drugs are used in low doses for a short time. Let's say a patient comes with delirium, a 80-year-old female patient comes with delirium and is agitated, and the drug, from the drug choices they have given, the only antipsychotic which is there is haloperidol. So you give haloperidol, intramuscular haloperidol, and you can use them as depot medications, which are long acting. These, once you inject it once, it will be in the system for a longer time. We will come to that in the next point. So for acute agitation, haloperidol is used, but again, Olanzapine is a better choice because it is the second generation and there's less side effects. For non-adherent patients, a hint in the question would be these patients have a history of being hospitalized several times. You need to inject a long-acting, such as Risperidone, Paliperidone, Olanzapine, or haloperidol. So this is called a depot injection. And in pregnant women, the number one choice would be go for electroconvulsive therapy. If they give a drug, then you go for this drug, Lorazepam. This is safe in pregnancy. In patients with the risk of aggravating torsades de pointes, an ECG should be done before the antipsychotics are prescribed. So if a patient comes agitated, if the patient requires immediate restraining, you can use lorazepam or diphenhydramine. This is an antihistamine drug to restrain the patient, to sedate the patient till an ECG is obtained, and you can put the patient on a antipsychotic. And again, if the side effects are very debilitating, you go for a second generation or you reduce the dose. Next, let's talk about the second generation antipsychotics. And I will highlight the most important parts. One of our strongest drugs is clozapine. This is the most effective medication for schizophrenia, period. However, this is considered second line due to the risk of agranulocytosis. When we do a blood count, you will see our white blood cell count has gone down. And also, you need to monitor these patients by doing complete blood count in this manner. So these patients really comply with this. Imagine for the first 6 months, they need to do complete blood counts every week. For the next 6 months, they need to do complete blood counts every 2 weeks. And after 1 year, they need to do complete blood counts every month, once a month. So it is hard to get people to comply for this. That makes it harder for us to prescribe this. This has a high affinity for serotonin receptors, and it treats both negative and positive symptoms. There's no extrapyramidal or tardive dyskinesia side effects, no movement disorders, no prolactin or sexual effects. And it is used for treatment-resistant schizophrenia. There are other side effects that you need to know, but the main one is agranulocytosis. There's a risk of seizures, metabolic syndrome, weight gain, and a lot of drooling. They drool a lot. We have a case of agranulocytosis. A 55-year-old woman with a history of schizophrenia fails to respond to risperidone and is started on clozapine. 6 months later, she presents with fevers, chills, rigors, weakness, sore throat, and fatigue, and her WBC count is very low. The treatment is to discontinue the clozapine and stimulate white blood cell regeneration by GCSF. Next, we have risperidone. This is like clozapine without the agranulocytosis. This is not as good as clozapine, obviously, and the side effects includes hypotension, the anticholinergic side effects, and all the other side effects we talked about. There's a lot of movement disorders and endocrine effects. Now, if we were to compare first generation, let's say haloperidol and risperidone, obviously haloperidol will have the worst side effect profile. But when we consider the second generation, risperidone has it more. Next, olanzapine. This is associated with the most weight gain and metabolic syndrome. That means these patients who are on olanzapine require at least every 3 months, they need to do a lipid profile and a blood glucose test. Next, Risperidone, lurazidone, quetiapine, and aripiprazole. These have lower metabolic risks. These are newer drugs. Lurazidone and quetiapine is the first line treatment for acute bipolar depression. You need to remember this. In a patient who has bipolar disorder, if they come with mania symptoms, instead of using olanzapine or haloperidol to calm them down, you give them lurazidone or quetiapine. This is the first line treatment. Next, we have a condition which is associated with first generation high potency antipsychotics, especially in genetically predisposed people, but it can happen to anyone. This case study tells us of a 42-year-old unmarried female, and 3 months ago she became very suspicious. She became paranoid and would accuse others of plotting against her for the past 3 weeks. She's given several intramuscular injections as she was very disturbed. On the second day of admission, she became mute and developed high spikes of temperature and labile blood pressure with severe muscle rigidity. The presentation of neuroleptic malignant syndrome is fever plus muscle damage and fluctuating blood pressure with reduced urine output. So for these patients, the first step is, because of the high fever, you need to manage that immediately, and the patient should be sent to the ICU. You need to first stop the medication, send the patient to the ICU. Temperature should be reduced using cooling blankets. Monitor the patient's blood pressure. Make sure the patient is hydrated, and you need to make sure that the kidney functions are protected. You need to check the patient's urine output, and you can give these patients bromocriptine or dantrolene. Once the patient is out of danger, and let's say the patient only responds to that causative drug, her psychosis only responds to that drug, you need to lower the dosage. Now, there's a question. Which drug is the first line for a patient with schizophrenia? Which drug should I choose? There's no specific answer like that. It depends on the patient. It depends on where you are. So they will never ask you, what is the first drug? Is it risperidone or olanzapine? They will ask you based on the patient's other associated symptoms. For example, patients who are already obese are unlikely to be given Olanzapine. They might go for Risperidone or one of the newer ones. And then if a patient is at risk of seizures, of Agranulocytosis, they will not prescribe the patient Clozapine unless they have to use the drug for treatment-resistant schizophrenia. Our next topic is antidepressants. Depressed patients have decreased norepinephrine, dopamine, and serotonin. And the goal of antidepressants is to raise the levels of these affected neurotransmitters. We use antidepressants in depression, in anxiety, in enuresis and panic disorders. The drug we use here is imipramine. OCD, we use fluoxetine and clomipramine. And chronic pain with and without depression, such as amitriptyline. When we talk about antidepressants, there is two groups. There is the newer types which we currently use, such as the SSRIs and the SNRIs, which are a part of the atypical antidepressants. The SNRIs are a part of the atypical antidepressants. And then, in terms of the real world, there's the MAOIs and the TCAs, Tricyclic Antidepressants. We no longer use these. In the real world, we don't use these because they are lethal in overdose. And there's a lot of side effects involved. Also, when you say a drug is lethal in overdose, especially in antidepressant patients, depressed people are at a risk of suicide. So the moment they get some energy because of these drugs, they might use that same drug to kill themselves. So we don't really use them in the clinic, but for the exam, we need to know these, we need to know the side effects, and we need to know how it's used. SSRIs. The SSRIs that we most commonly use are fluoxetine, sertraline, fluoxetine, citalopram, escitalopram, and paroxetine. There are some important things here, but what they do is they inhibit the reuptake of serotonin at the neurotransmitters. So the serotonin that is released is unable to come back into the cell that was releasing it. This is asked in step 1. They will ask you which process. They will give you letters and they will ask you which process is affected by these SSRIs. The reuptake is affected. And these are the most widely used antidepressants with the fewest adverse effects. And we use these for OCD, especially fluoxetine. Now, what are the adverse effects? There's no cardiotoxicity, relatively safe in overdose, and there's no anticholinergic effects. The ones we talked about in antipsychotic drugs, those are not there. Weight gain, loss of orgasm, and delayed orgasm. This is the main problem we have. GI problems include diarrhea and vomiting. Now, we have weight gain, loss of orgasms, and delayed orgasms. Especially in sexually active people, they may not be willing to use these drugs. So, if a patient complains of anorgasmia and delayed orgasms, the drug of choice is bupropion. We go for this drug. Let's take a look at the atypical antidepressants. Murtazapine, desvenlafaxine, duloxetine, venlafaxine. This is the active form. Venlafaxine is the active form of desvenlafaxine. Then trazodone, bupropion, and vilazodone. Now, there are some very important things I need to talk about here. If a patient has depression plus neuropathic pain in diabetes, if they have diabetes with neuropathic pain, we use duloxetine. If the patient has sexual side effects, then we use bupropion. And if a patient has depression plus insomnia, we use trazodone. So there are different scenarios in which we use different drugs. These are some examples. It depends on you as a doctor to figure out what else the patient needs. You try to kill two birds with one stone. And you need to know this very well. Trazodone causes priapism. Let's get into more detail about these drugs. The first one is Murtazapine. Now, I won't be talking about these because these are not really useful. Which receptors they activate? They cause, the side effect profile is very important. This drug causes weight gain. It is associated with weight gain. So if a person has lost a lot of weight and is depressed, this is the drug of choice. Because in addition to weight gain, they also causes increased appetite. Next, trazodone. This is highly sedating. Therefore, we use it to treat insomnia. See, the side effect is sedation. And we use this effect to treat insomnia. But this side effect must be known. Priapism is going to be tested. Since there is alpha-1 adrenergic blockade, there is a risk of postural hypotension. This also needs to be known. Next, we have Yoxetine. There is nothing special about this that you need to know. Varenicline. This is a nicotinic acetylcholine receptor partial agonist. So we use it also for smoking cessation. In patients who have depression plus the need to stop smoking, we can use this. But more commonly, we use bupropion. This is more commonly prescribed. This has the favorable sexual side effect profile. So instead of causing anorgasmia, this does not cause that. But you need to be very careful because it can induce seizures in patients with bulimia and nervosa. This will be tested. This is a very important point. Bupropion is a drug that is definitely going to be tested. Vilazodone is going to be used for MDD, and toxicity leads to diarrhea, nausea, anticholinergic effects, and may cause serotonin syndrome. There's nothing special about that. We will talk about that. Next, we have the tricyclic antidepressants. This is not used commonly in the clinics because of its side effect profile. These are old drugs, but then for the exam, we need to know these, especially amitriptyline, imipramine, and clomipramine. Nortriptyline, the others, decimapine, may also be asked. These two are rarely questioned. But in general, you need to know. What I say, to understand, to learn pharmacology and these drugs, you need to watch Sketchy Medicine. That's the best resource. There's no other alternative that will help you retain the names of these drugs, the use of these drugs for long term. But for step 2, you need to know which drug to prescribe. So for step 1, the Sketchy Medicine would be more than enough, and it will help you actually remember the drugs. For step 2, it's a bit more complicated than that. When we talk about tricyclic antidepressants, they inhibit serotonin and norepinephrine uptake. So this is similar to SNRIs. SNRIs is serotonin, norepinephrine, reuptake inhibitors. They inhibit the uptake of both these. And we use these drugs for bipolar affective disorder, OCD, clomipramine is used here, anxiety, people with suicidal thoughts, and imipramine is used to treat nocturnal enuresis. This is something you need to know. In addition to vasopressin, we use imipramine. Next, adverse effects. There's the anticholinergic effects, there's the CNS effects, there's cardiovascular effects such as tachycardia, orthostatic hypotension, and a way that these people are told to avoid this is to make the person drink coffee in the afternoon. And if there is orthostatic hypotension, it is going to be very dangerous in the elderly. Then sexual impotence, and in women there can be anorgasmia and breast enlargement. This is lethal in an overdose. This potentiates the effects of alcohol, so we do not let the patient drink alcohol with this drug. And mania episode can be induced in up to 50% of bipolar patients. Remember this, we don't give antidepressants to pregnant people. To bipolar people. We never do this. We have different drugs of choice, such as lamotrigine. We will come to that. If we are withdrawing the drug, it should be gradual, because in case that we suddenly stop the drug, there can be vomiting, cholinergic effects, dyskinesia, anxiety, and severe depression rebound. So you need to tell the patient to return to the doctor if they want to stop taking the drug. What do you do if there's a TCA overdose? So what presents are the 3 C's: convulsion, coma, cardiotoxicity. This is the most common presentation. In addition to that, you have respiratory depression, prolonged QT, hyperpyrexia, and to treat them, it's supportive. You can give sodium bicarbonate to prevent arrhythmias, and also activated charcoal to try to get rid of the TCAs from the system. Next, we have the monoamine oxidase inhibitors. Now, this is the drug which is related to tyramine containing food. So in a question, if they talk about a person who went for a wine tasting, who had all sorts of fancy cheeses, those are words that they use. Fancy cheeses, in the sense, processed cheese, are not going to contain tyramine. Processed cheese and white wine do not contain tyramine. But aged cheeses, dried fish, sausages, draft beer, chocolate, avocado, and red wine, these are the main culprits. These contain a lot of tyramine, and if it is mixed with MAOI, it can cause a hypertensive crisis. So the drugs that we talk about in MAOIs are the transcyclopromine, phenylazine, isocarboxacid, and selagelene. We don't use these drugs anymore. Again, I have to repeat it. We don't use these drugs anymore, but because these are tested in the exam, you need to know about this. So in a hypertensive crisis, the patient's blood pressure will rise rapidly. There's going to be occipital headache, stiff neck, nausea, vomiting, chest pain, dilated pupil, nosebleed. So a patient in a case study will come with the following presentation. Was at a party with the food, tyramine food, plus presents with symptoms of hypertension, increased blood pressure, sweating, dilated pupils, etc. And the treatment, you need to give them hypotensives such as phentolamine. You need to stop the medication, obviously. Now, let's take a look at a case of hypertensive crisis. We have a 42-year-old man who is brought to the ER by his wife after a wine tasting party. In the middle of the party, he started to feel uncomfortable, confused, and diaphoretic. His medical history is significant for treatment of depression. They will usually give you a clue like this. They have to. He is found to have an elevated blood pressure of 190 by 110 millimeters of mercury, and fundoscopic examination shows flame hemorrhage. This is a classic case of hypertensive crisis. And the patients must obviously be cautioned against eating these food. Next, let's take a look at the 4-week rule and the 6-week rule for SSRIs. An average antidepressant requires 2 to 4 weeks to work. SSRIs will take around 4 weeks, but there's a SSRI which requires 6 weeks. This is fluoxetine. So let's say a patient comes at 4 weeks on an SSRI and tells there was no change to his symptoms of depression. Then you need to change it. If the patient comes at 6 weeks on fluoxetine with no change to the depression, you need to change the medicine. If a patient comes in too early, that is before 4 weeks for SSRIs and 6 weeks for fluoxetine, you tell them to wait. If there is some improvement at 4 weeks, then we have to increase the dose. Again, same for fluoxetine. We increase the dose at 6 weeks. Now, as we know, depressed patients are at a risk of suicide. So what happens when we start patients on antidepressants? Before their depression is affected, their motor activity is increased. That means they get energy to do something like suicide. So we need to be aware of this. There is something called a window of suicide risk. And once the depression is settled, we need to continue the antidepressants for at least 6 more months to halve the relapse rate, to stop the person from getting depression again. Because once you have depression once, you have opened the door for you to get it again. Next, Serotonin Syndrome. This is when a patient is on too much SSRIs. If you give too much SSRIs, or you mix 2 SSRIs, or you mix an SSRI with an MAOI, or MAOIs with drugs such as MDMA, or SSRIs with any drug that has serotonin activity, such as dextromethorphan, which is used to suppress cough. What happens then is they will go into serotonin syndrome. If these drugs are mixed and the serotonin levels increase at the neurotransmitter junction, this will lead to restlessness, sweating, insomnia, diarrhea, cramps, and delirium. And also you will see words such as hyperreflexia and clonus. Let's take a look at this case. A 68-year-old man comes to the emergency department due to restlessness, agitation, and altered mental status. This is delirium. Pupils are dilated, hyperreflexia, and ankle clonus is observed. His wife states that the patient was prescribed dextromethorphan for his asthma yesterday. This is a cough syrup. He has a history of major depressive disorder treated with fluoxetine. So once you mix the SSRIs with dextromethorphan, you get serotonin syndrome. This is a typical case. The management for this is you need to stop the medication. You take the medication from the patient if needed. And then supportive care. The answer in questions would be you need to sedate the patient with benzodiazepines. They are agitated, they are delirious, they're restless, so you need to sedate the patient. And if needed, only if needed, you give cyproheptadine. This is a serotonin antagonist. You give it only if needed because it destroys all benefits of previous treatment. So immediate sedation, paralysis, and tracheal intubation is required if the temperature goes above 41 degrees Celsius. You treat the hypertension with a short-acting hypertensive such as esmolol. And again, I need to highlight this statement. Antidepressant monotherapy is entirely avoided in patients with bipolar disorder due to risk of inducing mania. Remember that mood chart? The moment a depressed patient is given an antidepressant, their mood goes up. And if it goes up above the normal level, this can lead to mania. And this increases the risk of suicide. Normal people will stop the mood going from this level. From the normal level, it will stop the mood going up. It will stop the mood elevation from the normal level. But the bipolar patients don't have this inhibition. It will continue to go up. Next, we have electroconvulsive therapy. This is when you attach electrodes to the patient while the patient is sedated, and then you pass electrical impulses. And it is used to treat depression, especially severe depression, and depressive disorders or psychotic disorders in pregnant women most commonly. In addition, highly suicidal patients will also have a lot of benefit from electroconvulsive therapy. These three patients will gain a lot from this. We can also use this in other disorders such as schizoaffective disorder, bipolar disorder, catatonia, NMS, Parkinson's, delirium. And it might sound as if this is an unsafe therapy, but in terms of pregnant women, this is the safest therapy for depression. So if you get a case which is going to ask you the safest therapy for depression, the answer is always going to be electroconvulsive therapy. What are the side effects, the absolute side effects of electroconvulsive therapy? There will be transient memory disturbance. There's going to be retrograde amnesia, which will resolve over the few upcoming weeks. Then there's a transient increase in intracranial pressure. And there could be cardiac rhythm abnormalities. Next, we have the electrode placement. This is just there for you. It will never be tested. They won't ask you how you place it. Patient preparation is also something that they won't ask, but it is good to know this. And the patient should be anesthetized because it is going to be a painful procedure. You are passing electrical impulses. The patient should be fasting, and there should be no metal objects in the body, and the patient should be asked to have a bath before the day of the procedure. Next, we have the mood stabilizers. These are used to treat bipolar disorders. And there are two types. There's the manic type, when the mood goes up, and the depressed type. So for manic type, people who are more prone for the manic types, there's lithium, valproic acid, and antipsychotics. And especially for acute reactions of mania, you go for antipsychotics. Then there's the depressed type. Here we have lithium and lamotrigine. Now you can see here, lithium comes for both. Therefore, lithium is the drug of choice to control bipolar disorders. Let's take a look at lithium. This is the long-term control and prophylaxis of bipolar disorder. Then for migraine cluster headaches, chronic aggression, and works for around 70% of the cases. The problem in this drug is this is a very narrow therapeutic index. So you need to reach almost toxic levels to gain that therapeutic effect. Therefore, we must monitor the patient's blood levels, kidney functions, and there should be adequate salt and fluid intake, because lithium is excreted entirely in the kidney. So a patient who has damaged kidneys or is on drugs such as hydrochlorothiazide, where the lithium won't be excreted, they can have a lot of side effects. So we will talk about these side effects. And one more thing to know, lithium works within 1 week. It takes around 1 week for lithium to start working. The side effects. This is a narrow margin of safety, so you need to monitor blood levels. You need to do yearly urine analysis and reduce the dosage as required, especially in older patients. I have highlighted the most important points for the side effects. Tremors, then it is teratogenic, there's a risk of Epstein abnormalities, then diabetes insipidus, and also hypothyroidism. You need to test patients' TSH levels every 6 to 12 months. We'll go through all the side effects from the beginning, but these 4 are the most commonly tested and the ones you need to be well aware, because this is what they will ask you in a case. They will give you a patient who has tremors, who has symptoms of diabetes insipidus, and also, or instead of giving diabetes insipidus, they might give you a patient who's hypothyroidic, who has symptoms of hypothyroidism. So you need to be able to differentiate these patients. Let's take a look. Tremors thirst, anorexia, GI distress is common. Seizures and coma, weight gain, polyuria, polydipsia, teratogenic. This is a problem. That's why we never give pregnant women lithium in the first trimester, because of the risk of developing Epstein anomaly. Diabetes insipidus. Now, the cause for this is because lithium excretes very similar to sodium. So the way lithium is excreted is going to be the same as lithium. Think of lithium and sodium interchangeably here. If we give the patients drugs such as thiazide diuretics, then the amount reabsorbed will be high. Therefore, the blood levels of lithium will be high. Or if there are causes of decreased GFR, if there are kidney problems, this can also cause lithium retention. You need to be aware of this, and you need to know that you will never get a patient in the exam where they tell you directly. They will give you hints, such as the patient is on a thiazide diuretic and is bipolar treated with lithium. Or they might not even tell you that. They will just tell you the patient is bipolar. And they will tell you of tremors, of hypothyroidism. You need to understand this is lithium toxicity. Next, we have hypothyroidism. This is a very common manifestation. Lithium destroys the thyroid gland. This causes an increase in TSH levels. Therefore, we need to test patients every 6 to 12 months for their TSH levels. And instead of stopping the lithium, we manage these patients symptomatically. We give these patients levothyroxine rather than discontinuing the medication. That fact is important. The lithium toxicity treatment is to stop the lithium, and you hydrate continuously. You get it out of your kidneys. You give a lot of isotonic sodium chloride, and if needed, you can do hemodialysis. Next, Palcroic acid. This is used in acute mania, rapidly cycling, bipolar disorder. This is the treatment of choice, and for impulse control. These are the psychiatric uses, but this drug is used in seizure control. The side effects that you need to know is hepatitis. So you need to do liver function tests every few months to years. There's no specific guideline for that. It depends on the patient. These are also teratogenic, and there's a risk of alopecia. USMLE Step 2 loves to ask you drugs which can cause alopecia, that is hair loss. Usually on the top of the head as a patch, on the side of the head. These are your eyes. There can be hair loss on the top of the head or to the sides or the bottom, and this is one drug which can cause that. Next, we have lamotrigine, and like I said earlier, we don't give SSRIs and those antidepressants for bipolar patients who have depression. We give these patients lamotrigine. This acts specifically on bipolar depression, and the side effect that you need to know is drug rashes. They will tell you a bipolar patient comes with a drug rash. What is the drug causing this? Lamotrigine. And remember, there is a risk of developing Stevens-Johnson syndrome, and if it goes any further, it can go into toxic epidermal necrolysis, which is basically your skin falls off. Next, carbamazepine. This is a second-line treatment. This blocks sodium channels and acts on GABA receptors. You need to monitor blood levels and for signs of a rash. This is not going to be the main drug which you need to know. For drug rash, lamotrigine is the one. They have a risk of agranulocytosis. So therefore, we don't use this. Side effects are similar to valproic acid, and it can cause Stevens-Johnson syndrome. There's nothing much you need to know there. Now, let's go into a bit of pharmacology and how to choose the drugs if a bipolar disorder patient comes with liver disease, we don't give them valproic acid, we give them lithium. But the opposite, bipolar disorder patients with renal disease, we use valproic acid. And bipolar disorder with acute mania, if they come with an acute episode, if they're brought into the hospital, you need to give them an antipsychotic, such as quetiapine or lurazidone. Next, we have the anxiolytics. We use SSRIs and SNRIs. It takes 1 to 4 weeks for effect. And this is considered the first line treatment for anxiety over benzodiazepines due to the risk of dependence and tolerance associated with benzodiazepines. Buspirone is a drug which can be used in alcoholics, but this also takes a week to start working. This affects serotonin and not GABA. This is the reason why we can use it in alcoholics. There are no withdrawal effects. Why would you have a drug like buspirone when you have benzodiazepines? Because if an alcoholic is given a benzodiazepine, they could die. So we need to make sure that alcoholics are told not to mix these two together if they are prescribed benzodiazepines in any sort of situation. Again, benzodiazepines work immediately. This is the drug which works immediately. This increases GABA action. But we use this for short term only. We don't prescribe long-term benzodiazepines. I talked about this in the anxiety topic, and we have the short-acting ones such as alprazolam, which is used for acute anxiety, diazepam, flurazepam, trizolam, and then we have the long-acting chlordiazepoxide, clonazepine, lorazepam, temazepam, and oxazepam. I gave the common uses here, but let's go into the more important things. The indications: anxiety, acute and chronic alcohol withdrawal. When the patient is on withdrawal symptoms, you can give it. Convulsions, insomnia, restless leg syndrome, akathisia, panic disorder, phobias. The adverse effects: it has a sedative effect, and there can be paradoxical agitation. I talked about this, especially in the elderly. It lowers the tolerance to alcohol, therefore it is potentially lethal. And also, benzodiazepines decrease the effectiveness of oral contraceptives. You should never suddenly withdraw these patients. It should be a tapering dose. It should be gradual, because withdrawal can suddenly cause seizures. It's a rebound effect. What it stopped, the moment you take it away, it is going to rebound. So seizures, agitation, anxiety, insomnia. And overdose can cause apnea and respiratory depression. Next, we have psychotherapy. This is the type of treatment where we interact with the patient. And the patient is taught to condition their moods, feelings, thoughts, and behaviors. And for step 2, especially, you need to know these. Cognitive behavioral therapy. You identify unhealthy, negative beliefs and behavior, and you replace them with healthy, positive ones, such as depression and anxiety. You find out in this patient they have anxiety because of someone who they're living with. You try to identify that and see if there are ways in which it can be corrected. Next, dialectical behavioral therapy. For dialectical behavioral therapy, what you need to know is it is used in borderline personality disorder because it helps these patients to manage their emotions, improve relationships with others. We have behavioral therapy, where we would cause the patient to unlearn something and then learn to change their reaction to that stimuli, such as alcohol use or phobia treatment. Systemic desensitization for phobia treatment. I have talked about how that happens. Next, we have interpersonal psychotherapy. This is individual, where you address problems in the current relationships with other people to improve your interpersonal skills. And this is usually done 1 to 3 times per week for several months. This is usually done when there's a defense disorder. If you are jealous, or if you project your emotions, if there's all these defensive mechanisms involved which are affecting your daily life, then individual psychotherapy helps. Next, I will talk about group therapy. When there are a group of people who have similar problems to yours, such as they are alcoholics and they are relapsing now, so they will interact with more alcoholics to get over their alcohol abuse or use. This is usually 1 time a week, and they go on for months to years. And remember, the psychiatrist will usually be there in that situation, and they will also aid the process. Next, we have supportive psychotherapy. This is simply you help the patient cope with stress and difficult situations such as the loss of a loved one, for grief and adjustment disorders. Next, we have psychoanalysis. We examine neurosis in psychologically minded people. This is done 4 to 5 times per week for years. This is not going to be tested. This is just something I added. Now, let's take a look at the case study. We have a 25-year-old man brought to the emergency department by his wife. She says that he has barely slept for the past week and has been working on miscellaneous projects around the house. He spent their life savings to buy tools needed for these projects. When questioned, the patient has rapid and frenzied speech. This is called pressured speech. He feels spectacular, and the patient has had 2 previous depressive episodes. Which of the following is the most appropriate long-term management for this patient? What is the most appropriate long-term management for this patient? The patient has mania and depression. This is bipolar disorder, and the treatment of choice is lithium or valproic acid for long term. If the question asked you for the acute symptoms, we would go for something like haloperidol or any antipsychotic for the acute mania. Now, what is the answer here? Valproic acid. Remember this, they will never give you 2 options of lithium and valproic acid. They will give you one or the other. And if they give you both, go for lithium, unless the side effect of kidney is given. Next, we have a 30-year-old patient who was recently diagnosed with depression and prescribed a medication. Several weeks after starting the medication, the patient's depressive symptoms have improved mildly. However, the patient is distressed due to a significant decrease in libido and impaired sexual performance. He requests an alternative treatment. Which of the following drugs is most appropriate for this patient? So the patient is distressed due to significant decrease in libido. What is the drug we are going to prescribe? Bupropion. A 30-year-old woman comes to the emergency department due to tremors and ataxia. The symptoms have gradually worsened over the past week, and she has difficulty walking. The patient has a history of bipolar disorder treated with lithium. She recently started a new medication several weeks ago. Drug interaction with which of the following is the most likely cause of these symptoms? Now, the patient has bipolar disorder treated with lithium and comes to the emergency department due to tremors and ataxia, which have gradually worsened, and she has difficulty walking. She has started a new medication several weeks ago. What do you think is the drug which is causing these symptoms? The answer would be hydrochlorothiazide. Next, we have a 78-year-old woman brought to the emergency department due to suicide ideation over the past month. The patient has a history of depression treated with venlafaxine. She has stopped taking the medication because she felt that it stopped her from joining the aliens. This is a patient who has depression with psychotic features, who visit her at night. So the patient is suicidal. She's old. Which of the following is the next best step in management? Regardless of the age, because of these suicide ideations with these psychotic features and depression, the best treatment of choice is electroconvulsive therapy. Next, let's take a look at some questions on interviewing techniques. A patient with apparent risk of physical abuse due to bruises in the body. What do you tell as a physician? Do you ask the patient, do you feel down or hopeless? I am going to call the police to investigate. These bruises are clearly from abuse. Or tell me more about the bruises on your body. You ask a patient an open-ended question. If you ask the patient, do you feel down or hopeless, that means you are already assuming something about the patient. You might get the patient on the defensive, or you might go on to an entirely different aspect which is not related to the current situation. I am going to call the police to investigate is a very bad choice because it could put the patient on defensive, because usually if a person is being abused by someone they are in love with, they will not give up the person they are in love with, and the moment you threaten them with calling the police, they will be silent, they won't tell you anything. These bruises are clearly from abuse. This is a confrontation, and we don't confront patients who are of apparent abuse. We confront drug users, suicidal patients. The best choice is to ask the patient to tell you more about the bruises on the patient's body. Next, we have a patient who's struggling to quit cocaine and is discouraged by repeated failures. I'm going to start from the bottom. I am hopeful that you can quit cocaine. You are putting the responsibility on yourself in this. The patient will be like, the doctor said I am hopeful that I can quit cocaine and I couldn't. He's useless. Option C. If you don't stop the cocaine, you could go into agitation and hurt someone. People who are using drugs, they know the side effects. So threatening them like this is never going to work. Medication will help you stop cocaine. This is not giving the patient an option. They are discouraged by repeated failures. You are pushing. You are leading the patient. The best option is you were successful in stopping alcohol. How would that experience help you quit cocaine? You ask the patient to open up to you, to tell you, and you guide the patient. You build a doctor-patient relationship there. The answer is A. Next question. A 40-year-old man was hospitalized for a psychotic episode. He improved rapidly with medication and was discharged. 3 weeks later, the patient comes to the emergency department due to generalized muscle stiffness and shaking in his right hand. He has no other medical condition. Vital signs are normal. On mental status examination, he is alert and oriented with mild paranoia but no psychotic symptoms. Which of the following is the best treatment for this patient's current symptoms? So a patient had a psychotic episode. He improved rapidly because of a medication you gave. But the patient comes to the emergency department due to generalized muscle stiffness and shaking of his right hand. This is drug-induced Parkinsonism. We do not give these patients levodopa. The treatment of choice for these patients is benztropine. We have discussed this. Next, a patient is diagnosed with schizophrenia and treated with Olanzapine. At the patient's 3-month follow-up, which of the following studies should be obtained? As we know, the second generation antipsychotics, especially the pines, olanzapines, these are associated with increased metabolic symptoms. So a patient who is on these drugs should be asked to do a fasting blood glucose and lipid panel when they come for the next visit. So this is the end of psychiatry for USMLE Step 1 and 2. And the earlier lectures were done with the draft notes, but this final lecture was done with the actual book, which is available on Amazon right now. Go check it out. I have added all the tables, I have added the case studies, then the answer explanations, everything into that.